Okay, so I want to go over the must knows for your live patient. I'm not printing it out and handing it to you or putting it on Moodle because I want you to actively listen and write it down. Doesn't that sound fun? So that way it's like in your mind. And then after we do this, then you're gonna, then we'll take a quiz. So, and I'm gonna try and do it quickly because I also have a huge PowerPoint to go over. So I'm gonna talk fast. So we'll just move right through this. So obviously sterilize your instruments is important. How might you do that? If you are a Monday person and it's 8 o'clock, Monday is your live patient, sterilize your instruments today or tomorrow. I mean, it's like it's the 9th hour. It's the deadline is hit. And how do you might not know, how do I do that? Well, you just bag them in sterile. Ask if somebody's been on a sterile rotation that's a classmate. You know, then just say, these are my XCPs, I have to get them sterilized. And when they're on their sterile rotation this afternoon, tomorrow, sorry, seniors are there, today's Thursday. If they're in there, then in the beginning of clinic, maybe they can just run a load. Does everyone think that that's totally doable? Yeah, all right, okay, I'm sorry, I'm not in there with you, so I don't always know like what to expect, but in my mind, it would work out like that. So just make sure that happens, because otherwise you really don't have any other time to sterilize them. And then if you are, you know, coming in later, then you're just going to do it. You're just going to do it when we get back, which is fine. Or you can try and do it tomorrow too. Yeah. So if you're using XCPs in your Friday lab and your 8 o'clock on Monday, then just use your XCPs and we'll just figure it out. I can't imagine there's too many of you where that lines up, but if you happen to be a Friday and your 8 o'clock Monday when we get back, then it'll work. We can always flash them first thing in the morning. There's ways around it. But for everyone else, if you don't have lab on Friday, they should be sterilized by Monday for when we get back. All patient info needs to be sent to the front office desk in real Axiom Messenger ASAP. If you have not done this yet, you have to do this. The front office is going to get mad at me. This has to be done today. I mean, everybody should have this done by now. And if you have any questions about it, all that information should have been through your EHR course. But you know, you go into Axiom and at the bottom of the screen, there's a little envelope icon dead center. The bottom of the screen, center of the bottom of the screen, it's a little envelope, click on it. The plus sign brings up a new email, put F for front office, it pops up, then just copy and paste all that new patient information. Does anybody feel like they don't know how to do that or hasn't done it? Ryan? If you don't have a patient, the front office has patients for you. And so you need to, I would walk down the hall and see Brenda and Sarah right after class. And the other way that they want things done is in EHR, have you guys talked about how to put in a patient needs request? Yeah. Because you guys need to know how to do that for a clinic. So you would do, it's the exact same thing. You'd put in, I need a patient, but since it's Thursday and they're probably waiting for you to do it, because they at this point, they kind of know who still needs patients. So they're kind of waiting, but they do have patients. So you just need to get there, tell them I need it, and they'll help you. You're good, because then they're gonna, and I'll get to that on this list, but they might send you information about medical history, and then you can do some stuff with that. That pretty much has your patient in the schedule, and you're good. So next, once the front office makes the chart for your patient, you must schedule your patient per what you learned in EHR. And I say that because I am not the EHR expert. So I'm like, per what you learned, schedule your patient. So they will create a new patient chart. That patient will have a number, an identification. And then you will take that name and number, chart number, and you'll schedule it into the schedule where you said on our Google Doc, when you picked Monday at 8 or Monday at 9:30 or whatever day it was, Sarah created a schedule based on that. So then you will schedule that appointment into that. And I'm, like I said, I'm not the EHR expert. So basically what I just told you is about as good as I can explain it, because I know there's, but Sarah did tell me that there's tutorial videos that you can reference back if you're like, okay, how do I do this again? There's lots of resources that you guys have been given through EHR. So those things must be done. The front office will notify you when your med history documents have been sent in through DocuSign. If it's a family or friend, you can do the med history like over the phone. You can get hard copies and give them to your family or friend and have them fill them out. And then, but basically what you have to think about is that information that's on the med history, it has to get into Axiom. So if the documents come in through DocuSign, you have to go find them in Axiom. They're probably scanned in there, or they're under forms or documents or something in Axiom. You have to find that information, and then you have to input it into a medical history. The same thing if you have a hard copy, or if you call your mom or dad or cousin or friend or whoever's coming in, you call them on the phone here in the clinic. You're sitting in front of a computer, you open up Axiom, you open up a medical history in their chart, you over the phone, you're like, any respiratory problems, and you go down the whole list. So one way or another, if you get that information into your Axiom med history form prior to the day of the appointment, the FMX, it just saves time, because you have it all in there. You don't have to actually physically add it in. So try and plan to get that done if you can, because it really will save you some time. So arrive a little early so you can set up your room while you're waiting for your patient to arrive. It's first come, first served for the room. So those first 4 people that come in, the rooms aren't assigned. You just pick the one. And remember, it's not Dexter. All the rooms are pretty equal if you're not putting Dexter, because now we have the new unit in room 268. It's a brand new unit. So there's really no units that are awful. It's just the Dexters that are kind of awful. And so you don't have to fight over a room, but it's first come, first serve. And I mean a little early, like 7:45, 7:40, you can come in, put in your barriers. If your appointment is at 9:30, somebody likely is going to be in a room finishing up their FMX, but you can seat your patient somewhere else, like at the table, and take vitals. You can get your vitals done. So you can bring your patient back a little early, like 10 minutes early maybe, but not too much more early than that. And sit down and take all their vitals. And then once the room help the person turn over their room maybe, and then get going, so we can kind of help the process move along. So you can come a few minutes early, just don't. And if it's somebody that you, like it's a family member, you can kind of keep tabs with them with like texting, like I'm in the parking lot and stuff like that. But we still have to kind of follow the procedures of like patient procedures. So you're going to set up the barriers. You're going to cover everything. You're going to cover your keyboard and your mouse and places where you're going to touch. You're going to cover everything. You're going to retrieve your patient only when the ready button at the bottom of the screen is a little bit toward the left. Sometimes it says alert. Sometimes it just says different things depending on what's going on. But when your patient is checked in and ready for you to get them, that's when you'll go up and retrieve them, and will turn green. It says RDY. So you have to look at Axiom. And then I forgot to write this down, and thank goodness it's just now coming to me. So when you have brought your patient back, you're going to go in there and you're going to seat your patient, and it's going to change the color. So that's super important. So it's and I can't think at the minute like how to do it, but it's actually really easy. It's like you right click and then you'll see seat patient. So Teresa and I would be able to do that, but just write that as your next one. When you sit your patient, you need to seat your patient, and it's a computer change letting the front office know when you sat your patient. So now we know where your patient is in the building. They're with you in the operatory. No PPE on when you're retrieving your patient except your mask. So you cannot go up there with your overcoat or your face shield, blah, blah, blah. Take patient's vitals, review medical history with the faculty. We'll swipe that off after we go through that. Some things about taking films. Now we're transitioning into the actual process. Remember that when your patient sits in that chair, this hasn't been a thing really very much with Dexter, but last year you come in and people would be like, kind of like sitting like this and their heads like that. And they're trying to take x-rays and it's like, oh my gosh, we didn't even think about this. First thing first, give your patient good posture. They need to sit up straight. Their occlusal plane has to be parallel to the floor. That's patient positioning is huge. And if your patient is super like relaxed and slouched out of their chair, it's going to be really hard for you to think about the proper angulation, vertical, horizontal angulation. So sit up, patient sitting up nice and straight, no slouching, horizontal plane for their occlusal plane. Start with the bite wings. Use the Q-tip, do your best to open contacts. We want to open contacts with our bite wings. We don't want to try and have to juggle opening contacts on a PA if we can help it. Let's take your bite wings first. They're easy for patients to handle and do your best to open those contacts. Take your PAs next. The first film that you take that is a bummer, come and get help because it could be just a bad start and you'll improve and that's fine. But the last thing we want to end up with is 9 retakes at the end of your FMX. We want to minimize it just so that you have a good experience and feel successful and your patient doesn't have to sit there having a bunch of retakes. So the minute you take, people sometimes kind of panic and go, oh, I'm just going to take it again. I know what I did wrong. I'm going to make it better. And the next one, and then they take another one and something happens. So just come get myself or Teresa. Start with your sterilized XCPs. We have cushion stickers. Oh, and I say start with yours because I mean, we do have alternatives. If someone has a small mouth, you guys have already experienced this from your you're practicing on each other. If someone has a small mouth, they're gagging, it's hard, there's all the things that can happen. We do have a cascading flow of choices, but we're going to start with your sterilized XCP. We do have cushion stickers too that help soothe the edges a little bit so it doesn't feel like it's cutting into patients. Salt for patients who gag, that we haven't really talked about it, but if someone's gagging, there's things that you want to do. For one, you stay calm because it helps when the patient doesn't think that you're freaking out too, but it's easy to get flustered, trust me. But we can put a little salt on the tip of their tongue. It's very distracting. And so it helps their brain. That's all we are trying to do when we're trying to make our patients not gag. We're trying to distract their brain. The other thing that I didn't write here, but the minute you start that gag reflex, it's very hard to calm it down. So we don't want to keep going and keep going and keep going and making the same sort of error, like not error, but the same thing that's causing them to gag because it'll just get stronger and stronger. So a couple of things, if they point their toes, they breathe through their nose, they focus on something, it helps sometimes to get it through. And then when you say, I'm just going to place it here for a second, breathe through your nose, I'm going to run out the door and push the button, and you just show them that you acknowledge their discomfort and you're doing everything in your power to get it done fast. Hopefully nobody has any major gaggers, but that's practical information for you to take with you your whole life. Move quickly, but you also want to make sure your pictures are carrying out. So think about how long you're spending adjusting your BID. The minute you put that sensor in your patient's mouth, it could be uncomfortable. So you want to move quickly, but you also don't want to have a major retake or error. But the time to move the fastest is once you've gotten everything where you want, get out of the room and push that button as fast. No like sauntering out of the room. That's your best opportunity to move fast. And you can also tell your patient, listen for the beep. Once that beeping has stopped, you can take it out. Give them a little bit of control, and they like that a lot. Seat your XCP fully. Have the patient, before the patient bites down, seat it fully so that their occlusal plane comes to the bite, because that way they're not trying to seat it by biting. So you try and always seat your XCP totally down to the occlusal plane before you tell them to bite down. Tell your patient not to move, run out of the room, push the button as quickly as you can, but don't hurt yourself running out of the room. but that's your best opportunity to gain some speed. The minute you feel you're struggling, get help. You guys, we are here to help you. Critique your films. You're all done. Whew, take a nice deep breath. You're done. Critique your films just like you always do. Flag myself or Teresa. We'll grade your FMX. Then we're going to talk about your AAP and whether or not this is a good patient for you to see in the spring, or if you should keep them for your senior year, if their AAP is healthy, or if they're actually active perio. So we'll just have a discussion. This is just an estimate. It's not in stone. It's just an estimate. And then you have to tell that to the front office up front. We're going to complete the codes, which is pretty much planning the complete series and then planning the code and then completing it. So that's kind of more on myself and Teresa. It's just more of a note, but we have to make sure we do that. Then you're going to walk your patient up front, take off all your PPE except for your mask. Stay up front until you're excused. You can't just drop them off and say, bye, I'm going to go clean my room. You have to stay there with the patient and talk to Sarah and Brenda until they excuse you, and then come back to your room, clean up with your utility gloves, and you did it. Yay! Are you guys ready? They're just going to check them out with their process. They're going to make sure that the codes are in there. They're going to write down what the estimated AAP is. They might talk to them about coming back in the spring or not. They're just going to have their, I'm not sure exactly, but they're just going to do their kind of closing.
And then when we critique the film, is that when we decide we're going to do retake stuff for the patient stays on?
Yeah, so you'll critique them, and then Teresa and I will come in and we'll talk about what films need to be retaken. Yeah, so there may be some retakes at that point, but you'll critique them first. Yeah, and critique them for retakes. So you'll tell us, you'll say, well, I think I need to take this one and that one. And then we'll either agree or disagree, and then we'll come up with a plan. Yeah. Okay. Okay. That only took 17 minutes. So now we're going to go right from that little, why can't I minimize it? Okay. So now we're going to go right from that to our quiz. You can, so what you can do is when they're here, if your patient doesn't know where to go, like they park and then they're like, what building are you in? Where are you? Then you can just go out and get them, walk them into the front office lounge area, whatever that area is, and then just leave them there and come back. And then you can go back and get them when the light turns green, when they're ready. Yeah.
And they can go like the first level parking.
Parking, I am not sure about. I would probably ask Sarah and Brenda because they tell the patients all the time where to park. So I would ask Sarah and Brenda, or Alma might know too, but I'm not sure where patients park actually. Probably anywhere along the street, I imagine. Oh, there's a whole patient parking? Oh, that's probably good then. Yeah, that I'm not totally sure about.
Yeah, I mean, yeah. I know.
Okay, this is for the quiz. That is an M. Yeah, you guys can start. Yeah. I can help you with the codes, but we'll help you in the moment. And do you not have a computer to take the quiz?
Oh, I do. Sorry, I'm so concerned about this.
I know. Okay, so everyone should be starting the quiz now. And hopefully this will not take you very long at all. You don't have it? You know what? Let's don't worry, we'll take it after the class. You can take it after. Or let me try and open it up. Hold on. Did you just not download it? It's okay. Oh, okay. Okay. Hold on a second. That is an M. Yeah. Sorry, my M looks funny. You may be able to download it now. Try again. Are you really? I think everyone, is someone still taking the quiz? No, everyone's done? Okay, I thought everyone was done because I think we have a few missing today. Okay, I want to review it with you guys really fast because this is important information. Let me get to a safe screen where you guys cannot see things I don't want you to see. Hold on just a second. View assessment. Okay, I think I can share this now. Okay, so I want to just review with you these questions because clearly, you know, not everybody knew these answers. So, okay, but the two that people missed the most were obviously stuff that I didn't talk about just now with the live patient. But these are really important things for you to carry on with you into your next semester. So it's stuff that you just barely have been grappling with and grasping and working with. So it's not something that you're expected to be an expert in, but it's critical information. It's critical information that you're going to use for the rest of your career. So this isn't what's happening inside the tungsten target. This is what's happening with you as a practicing dental hygienist. Yeah. Uh-huh. So half of you, so 48% of you got it correct. So your patient's last bite wing set. So this is a critical thinking question that's pulling in information from all the stuff we've talked about. So when we talked, remember when we did those in the beginning of the semester, we talked about when somebody is due to have bite wings and stuff like that. So it's pulling in that, it's pulling in like who gets a horizontal bite wing, who gets a vertical bite wing. So it's pulling in all these elements. So it's a hard question, but it is a question that is encapsulating all the stuff that we, things that we've learned. Sure. Well, let's answer it first. Let's talk about it first. So your patient's last bite wing set are from 18 months ago. His last FMX was taken under 3 years. So that kind of makes you think, okay, it's been a while since he's had bite wings. Chances are I can kind of think, yeah, he's probably due, but it's less than 3 years since it's been an FMX. So I don't think he's due for an FMX. His overall AAP, this might have tripped you up. What's AAP? Well, we talked about it, but it's a new term for you. You haven't been in perio class. You're going to hear about it till you turn blue in the face. But the AAP is the whole lecture that we talked about bone level and staging. That's the AAP. So it might have been familiar just based on your studying for your proficiencies and understanding diagnosing perio on films. So his overall AAP is stage 2. So his staging is, like what we might consider mild to early moderate bone loss. So it's not like his teeth are falling out. He's got somewhere between 15 and 30% of bone loss. If you guys remember back from what we were talking about as to what stage 1 is, 15 or less % of bone loss, stage 2, 15 to 30. So, and then when we get into stage 3 and 4, there's more complexities like with clinical attachment loss and missing teeth and frications. So, but the chart narrative, I don't like why that, no, I don't understand why that N is not connected to the word, but the chart narrative says stage 1 with localized stage 2. So this is kind of telling you, this is trying to give you some information that he's not that bad, but he is a perio patient. So that's kind of what you would derive from this. He's not horrible, but he is a perio patient. He has AAP staging of perio. What type of x-ray should you take on your patient today? So basically, you're like, well, not an FMX because it's been less than 3 years. So that's, scratch that, right? Does that make sense? Not a pano, because we didn't say anything about wisdom teeth or impacted this or problems with that. So nothing that would really lead you to think it was a pano. Does that make sense? So then you're like, vertical bite wings, horizontal bite wings. Pretty much your mind should go in this place. If it's a perio patient, chances are, unless you can look at previous x-rays that have said they've always done horizontal and you can always see plenty of bone, but generally, if it's a perio patient and all you're taking is bite wings, your mind should go to vertical bite wings. In practice, in clinical practice, you're going to be asked multiple times, and certain faculty are more sticklers than others. Why did you choose horizontal? Why didn't you choose vertical? And you just need to know why. What was your rationale? We see a lot of perio patients, and so you should expect to recommend vertical unless you've looked back at past radiographs and they've always taken horizontal and they always see a lot of bone. So you always have to have like a rationale for why you choose. But that's basically just the given fact that you have a staging, a perio staging, they're an active perio patient or a maintenance at very least patient, should lead you to vertical bite wings. Does that sound familiar? Do you guys feel like you've heard that at one point? I just want to make sure that it also is a check for me. Am I giving you this material? Do you know what I mean? Ryan's like, nope, never heard it once. You have a set that are from 18. Well, it just says you have a. Yeah. 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 I think that's probably overthinking it a little bit. It's good, but I think it's probably overthinking it.
I think I have stage 2 a lot.
Yeah, I think it's just I think it's really good that we are having this conversation, because this is going to follow you for the next year and a half. This is hygiene, and this is what you do. You'll think about what kind of x-rays your patient needs. So I think you guys are I think it's really good that this question is asked, and then you get to kind of absorb this information and think, oh, this is what I would do when I come to this situation. Yeah, Anna. I chose 18 months just as an arbitrary number, because in those in that radiology, like where you decide what you need for your patient, a lot of them say, from 6 months to 18, or 6 months to 18 months, or 6 months to 36 months if they're really low caries risk. It just depends on their risk. And so what you can do from this is you can look at it and say the big picture. So not getting too zoned in to what you're looking at. The big picture is they're definitely due for bite wings. They're not due for an FMX. That's like, so being a hygienist, you look at your information that's given, and then you just, you take it, and you guys will get better and better at this every time you see a patient. You're not expected to do it right now. I mean, it's the first semester, but this is this is kind of like a taste of the state of mind. You look at the information that you're given, where your patient's at, and then determine like what their needs are from there. So you can kind of gather some of that information from the question. But yeah. Well, this one could be localized in just their molars. And so if it's localized in their molars, but they don't have it, say, premolars forward, you'd still want to take vertical, because you'd still want to make sure that you have plenty of bone that you can compare to whatever was taken last time, like the PAs or whatever it was. It pretty much, it's usually just perio patients, but then you can compare it to what was taken in the past. Yeah. Go ahead, Katrina. Yeah.
What if the stage 2 was in the anterior for the vitamins in the pattern? Does it matter like what that area is?
I think you guys are just we're reading too much into the question. So the question is really trying to give you a loose guide of how you would determine what kind of bite wings. If that patient is in front of you and all their bone loss is between their anterior teeth, but I wouldn't make a question based on that. So I think you're just overthinking it a little bit. Okay, next question. So this one was better. 79% of you got this, so this is good. So what do the little pictures of the teeth on the panels outside of the room of the x-ray correspond with when you're taking a film? So the reason I ask this is because every once in a while I notice that you're taking a film, like you might be taking a molar shot and it's still on the anterior. So I'm like, I think maybe not everybody has gotten the memo. So I wanted to ask a question to clarify this. So, and I think most of you do know what it corresponds with, per, 80% of you answered it correctly. So that's good. It is, you can't change, and this goes back to the beginning, you can't change MA and you can't change KVP on our machines. When you look at that little panel, remember it says 65 KVP and like 7 MA. Have most of you like looked at the panel and actually seen that? Does that sound familiar? So you can't change those things. So when you're pressing those little buttons, the only thing that you're actually changing is the exposure time, the amount of time that the radiation comes out of the machine. And you're going to do that based on if you're working in an area that is very dense, like a posterior area where there's a lot of bone, as opposed to maybe an anterior area where it's less bone. So that is what that's referring to. And most of you, I think, got that. But that's important because next semester, when you're working on real patients and your clinical instructor comes over, And it's like, why are you taking this? You know, I want them to know that you learned that in radiology and you have retained that, because that's how the machines function. So you need to know that. Is it, and 62% of you, is it a safety requirement by the state to cover your patient with a lead apron prior to exposure? It's not a requirement. We do it because it would take, and this might trigger your memory, but it would take a lot more time to explain to every patient why we're not putting a lead apron on them than it takes just to throw a lead apron on them. But it's not required anymore. So you might go work for an office that doesn't use a lead apron. During your live patient exposure, I already told you, take your bite wings first to open. So 79% of you heard me when I just said that. So during your live patient experience, just make sure you take your bite wings first, and for real, take your bite wings first, because you want to open up your contacts. And during your live patient experience, you guys heard me on that one. During your live patient experience, get your help. Now, yes, obviously, when you're taking films, when you take a molar shot and it doesn't turn out, usually sometimes you might just move to your premolar, but I was specifically referring to your live patient. So, okay. We have no time to go any more into that. So I am going to move right into the next topic. And I'm going to share my screen. This is all being recorded, so you guys can go back and listen to your heart content. We're going to go over the longer one first. And so since we are only going for another hour and there's a ton of slides to show you, I'm not going to break. Anytime you're just sick of hearing my voice and you need to get a little bit of air, feel free to leave and come back in a timely manner. I'm just going to talk for an hour because there's so many slides to show you, and I want to make sure I get to them all. But please feel free to get up, go out of the room for a minute, take a bathroom break, but just don't stay away too long because I'll miss you. And I'll know who left. No, probably won't know. Okay, I'm gonna get this up. I am recording. Thank you. Okay, teeth abnormalities. Abnormalities of teeth. Wish that I could just advance it with my space bar. So we're going to talk about abnormalities in relating to tooth numbers, size, shape, structure, and eruption pattern that can be seen on radiographs. So remember, everything that we talk about is always in the venue or whatever, the arena of radiographs. That just says the same thing. So a couple definitions. Anodontia is the absence of teeth. Star that. That's a good exam question. Hypodontia or oligodontia is partial anodontia. One or several, but not all teeth are missing. So these are just some terms. Their most common is the third molar or the maxillary lateral incisors and premolars. So if somebody's going to be missing a tooth, congenitally missing a tooth, oftentimes it's those teeth. If the premolars are missing, oftentimes you will get an ankylosed primary molar, which means that primary molar never loses its roots, and then the roots kind of ankylose or fuse themselves to the bone. Here's just an image of what it might look like. This is, you can tell this is a child because, sorry, I didn't mean to advance it that fast. You could tell that was a child because you could see the mamelons on their anterior teeth, and then you could see their primary dentition mixed in. Here's a primary molar, and you can see there's nothing below it, and you can see you still see those tiny little widespread roots. A little bit of resorption has happened over here, but there's no permanent tooth premolar to push up and get that. So that baby tooth's gonna sort of ankylose itself to the bone, likely. Here's a pano with some hypodontia. You guys might want to turn up the lights down just a little bit. There's lots of films. Here's another retained baby tooth. Isn't it sweet? And usually, I mean, the roots are really small, but I've had elderly patients. It's not as common, but I've had elderly patients with retained baby teeth. So depending on how hard they are, like on their mouths, and their diet and their oral hygiene, they can retain them. But you can see how there's bone loss around it. See, the CEJ is way up here, and there's bone loss all the way down here. So it is hard to retain one for someone's whole life. Usually they lose it midway and they need like an implant or something, but they can stay in there, some people longer than others. Defects in the number of teeth. So we have hyperdontia, which is one or more extra teeth. And then we call that supernumerary teeth. A supernumerary tooth can also be a Amnesia Den, a maxillary Amnesia Den. So supernumerary teeth can happen anywhere in the mouth, but if it's in between maxillary central incisors, it's called a maxillary Amnesia Den. So there's kind of a couple names for the same thing. Supernumerary teeth, yeah.
So would that not help hurt the mandible at all, or is there? Like,
Usually, I think Amnesia Dens happen in the maxilla.
Is there common to happen in the mandible?
I think it can. You can have an extra incisor on the mandible too, but I think it's just most common in the maxilla.
Is there like a term for that, or would it just be mandible?
Amnesia Den. I think if it's between the centrals, it would be a Amnesia Den, but otherwise it's probably just a supernumerary or an extra tooth. So here's an image of an extra premolar. So this is a supernumerary extra premolar down in here between the two adult premolars. Here's an intraoral image of a couple extra premolars that are lingual verted here. And then kind of what you were talking about, we have, if you count the teeth, I wonder if I put my, yeah, 1, 2, 3, 4, 5. So there's 5. So we have an extra one right down here in the middle of the supernumerary tooth there. Then we have, this is just another example of another premolar. Yeah, oh, lots of hands. Those are just supernumerary premolars. They're just extra premolars. So all of these are kind of just visual examples of supernumerary teeth, and they're typically premolars. You see that a lot. You also see little extra wisdom teeth. Sometimes people will have 4 and then they'll have like a little extra baby wisdom tooth. That's a supernumerary tooth. So here's a couple. This is like a little, a whole bunch of little ones forming around these premolars. So you can see it's more common around premolars since there's so many visual examples of it. Here's a little one between the lateral and the canine. There's a little supernumerary tooth here. And then here's another image of Amnesia Den. So it's in between 8 and 9. And then there's like this little extra tooth right in between there. Amnesia Den is a supernumerary or extra tooth inside your the mouth, often located behind or between the central incisors and the palate. So I think if it's on the mandible, it's not Amnesia Dens, is what I'm sort of gaining. It'd just be a supernumerary. Here's a picture of a little baby tooth hanging out behind. This looks more like a second molar to me because you got your premolars here. So this might be the wisdom tooth, and that's all it could muster. This can't be any bigger than that. So that's I think that's what that is, because that looks like the space for the first molar. Here's another little lateral, or it's, who knows what it is, but it's behind between the canine and the lateral. Here's an intraoral image of Amnesia Dens. I think this is the same one that we saw in the X-ray. kind of a weird picture. They have, you can tell they have disclosing solution on their plaque. And I think that's why it's so dark around. See how it's kind of dark in all these areas? I think that's disclosing solution. So then we can have defects in the size. And so things can be kind of overlaid, like those, like the little laterals or the little supernumeraries. They can also, you know, they're also like a micro or a microdontia as well. But usually we name them supernumerary first because they're an extra tooth, even if they are a smaller extra tooth. So microdontia or macrodontia teeth that are larger than normal, microdontia teeth that are smaller than normal, and the most common is a peg lateral. So laterals, maxillary lateral teeth can come in smaller, more commonly than any other. So here we have a lateral that is a macrodontia. It's larger than normal. You can see it's closer to the size of the central, and usually that's not the case. Usually it's smaller. And then an image of a peg lateral here, and it looks like a little peg. That's why they call it a peg lateral, because it kind of tapers off and looks just like. Alterations in tooth shape. So we have a couple terms. This can get a little bit confusing and a little tricky when you're identifying it in the mouth. So the first one, fusion, it's the union of two adjacent tooth buds by dentin or enamel. So you have two tooth buds and they fuse together. So two separate buds trying to fuse together. Gemination is the aborted attempt of a single bud to divide, to twin. So they can look similar in the mouth, but you basically just have to count the teeth, and then it can help you determine if you're looking at fusion or gemination. Concrescence is the union of the roots. They'll kind of be like wrapped around each other of two different teeth, and they're usually only connected by the cementum. So we'll see some pictures of that in a second, but tip, so count the teeth when you're trying to figure out gemination and fusion. If there's too many teeth, then you have gemination. If there's not enough teeth, then you have fusion. So if the lateral and the central fuse, or if two lower anterior teeth fuse, then you wouldn't have as many teeth, right? Like let's say instead of having 4 incisors, you have 2 because you know, 24 and 25 fused. So then you'd be counting them like 3 teeth instead of 4. But one of those teeth would look big because it would be 2 teeth fused together. So visually it would look like you have 1 bigger tooth and then 2 smaller teeth. So we'll look at some images here in just a second. So here we go. So we have, I believe this is the canine. This is a little tricky to tell actually, because it's not very pointy. But I believe this is the canine because the root looks longer to me. So then for incisors, we have 1, 2, 3. And so then you can say, okay, well, I know there's supposed to be more than 3 incisors. There's supposed to be 4 incisors. So then these have actually fused together. This is fusion. And then here we have an example of gemination, and you can't really count the teeth in this image because it's not big enough. But if that was in the mouth, then you would count these. You might say like 1, 2, and then 3, 4, 5, because maybe you'd count the other lateral that's over here, and then you'd go, oh, there's 5 laterals? Wait, what? And then you're like, oh no, that's too many teeth. So therefore 1 tooth tried to divide. And that's where you're getting that extra tooth from, is it looks like it's divided. So if there's too many teeth, it's gemination. If there's too few teeth, it is fusion. So here we have an example of fusion. This is a little easier to see it since it's not on an x-ray, but you can see where the canines are here and here. So we have 22 and 27, and then you count, this would be 23 and 24 fused, 25 and 26. Yeah. Yeah, that's a good question. Probably the X-ray would help because you could probably tell if it looked like their pulp chambers look different. So if somebody was like just missing a tooth and then they had a macrodontia, that would probably be something that would be tricky to figure out, but you probably could figure it out like with the dentist's help and kind of talking it out with the people around you. But that's a great question because I suppose you could technically have some funny situation like that. They do look big, but sometimes that just I sort of thought maybe it was a kid for some reason. I don't know why I'm thinking that. And sometimes their teeth, but their laterals are also a little, this lateral looks a little pegged to me. So I think more than anything, their laterals are a little bit small. And they also could be transitioning. If they're primary teeth, then the permanent teeth always look big. It's a little bit hard to tell. I don't think that they're that young though, because they don't have any mamelons. Well, they have that one, but they got a lot of wear on their teeth. It's kind of a hard picture to determine, but it could be, yeah. If it's a child that grinds, they can grind off their mamelons very fast. So it's a little bit hard to tell from that, but yeah, a lot of times when 8 and 9 come in and they still have primary teeth, they can look very large. And then also if their laterals are small, they'll look, their centrals will look bigger. Okay, so here's an example of gemination because you kind of have what looks like the 8 and 9 tried to divide in half. So they kind of get these little, oh, sorry, come over here. So you get these little kind of split lines over here and here. This, you can see there's the right number of teeth. You got your laterals here and here, but 8 and 9 look like they tried to divide. Here's another example from an intraoral photo of gemination. You can see these two teeth tried to divide. And then if you count them up, this is a permanent incisor. And then these are probably all, these are probably all baby teeth, just from the fact that this has mamelons and these don't. But you can, if you count them up, it's like 1, 2, 3, 4, 5. 5 incisors is too many. Or this actually could be this actually might be where their canine should be. Maybe it's their canine has tried to divide. Some of these are just kind of tricky to figure out exactly what's going on. So here is, if this is that person's x-ray, then that was a canine, because here you can see the canine here, that's the premolar, and then you can see how it's 2 teeth. But did someone have their hand out? No. And here's another fusion, yep, and you can kind of see how. And if you could see all the teeth, then it would be easier to Here's a picture of concrescence. So here's the roots of 2 teeth that have kind of fused just with the enamel. And this is what it looks like on an X-ray. Yeah, it would be really challenging. This one is probably, I'm imagining one had to have been, I mean, this has a filling, so I'm imagining this must have been impacted. So I don't know, I mean, that's a pretty wild surgery. That's a pretty crazy oral surgery to get both of those out. Now we'll talk about alterations in tooth shape. So a couple more terms. We have dilaceration, Taurodontism, and supernumerary roots. So now it's not just supernumerary tooth, but actually the number of roots. So dilaceration is bendy, curvy roots, usually result from trauma during formation or eruption. Taurodonticism, think of Toro like a bull. It's basically like, when you see pictures of it, the pulp chamber is just very boxy looking. And so I have to admit, someone's going to have to tell me why they think Toro is part of the word like a bull, but it just looks very like boxy. And instead of tapering nicely, it like the pulp chamber is much larger and more rectangular than it just looks odd. It doesn't look like what you normally see. So we'll look at some pictures of that. And then supernumerary roots you think of all your teeth that you just typically have one root, so like your canine or your first premolar, you just typically have one root, but if you have two, then that's an anomaly or an extra root. So this is what dilaceration looks like. Sometimes it's just a little bit wavy, and sometimes it's like really wavy. So you can see this is not that uncommon to see some curvature, but when it's really bent and wavy, it's a nightmare to do a root canal, and it's a nightmare to extract if the tooth ever has to be extracted. So if there's a curve at the bottom of a premolar or any tooth, and then an issue happens with that tooth, it makes for a lot of problems with the patient and for whoever they're seeing, the specialist. Here's another couple examples, and see why that's a, oops, oh no, go back. See why this is a problem here. It perforated the bottom of the apex of the tooth. So this, when they were doing the root canal, they perforated or went right through the bottom. And so now you can see there's this big radiolucency around here, because they didn't know, or they miscalculated, or whatever the issue was, but they went too far. And because you can see how if this tooth needs a root canal, see how they need to curve this somehow. And don't ask me how they do it, because I'm not an endodontist. Yeah, Woody. It's forever. It's pretty much a problem. They can do something called a apexotomy or something. I can't remember the official term, but they can actually clip it and like remove that part and hope that somehow they can like seal it, and then your body will encapsulate it. But it's not, I mean, I think nowadays they're like, let's just take this out and put in an implant, because doing extra, that's like heroics. It's like heroics on a tooth, and it's like, it's probably not going to work out. Not necessarily. They might have a draining fistula or a draining like pimple, boil on their gums. And it could be just chronically draining. Chances are it's probably not really painful though. But they could feel something. Okay, is this the right direction? I think so. So here are some supernumerary roots. So you can see here, we have a canine that has like a little extra tail or something happening down here at the bottom. So that's pretty unusual. And then we have a mandibular molar with, so that would, now how confusing would that be if that was on a quiz? That'd be like, wait, which way do I turn it? Because doesn't that look just like a maxillary molar? So yeah, that one would be really tricky. You don't see that very often. So that's a little extra root. And then here's one that was extracted. It looks like a little, like a tadpole. What do you call it? Tadpole. I'm like, what do you call those things? It looks like a tadpole. A tadpole. It does, or I mean, it looks like an alien. Let's just put it that way. A jellyfish or a squid swimming. Yeah, it's very bizarre, but that's what that is. So yeah, and it almost looks like it grew that extra root like on the outside only. That's very strange, but anyways. So here's a bifurcation on a second premolar, which is actually not, well, no, first premolars can have it. So second, oh, I always get it confused. Anyways, first ones, the assistants, you guys will remember. One of them, the ones that they always take out for ortho. Yeah. So, but then that's what you're seeing here is the bifurcation on this guy. And for some reason we have this again. Okay, so here's an image of Taurodantism. Take a mental picture of this. This is a good exam question. Taurodontism, see how it looks real blocky right through here? So it doesn't taper and the roots look funky. And that's probably maybe the bottom part of it is what they're thinking looks like kind of like the horns of a bull or something, because they come out like this instead of tapering like you'd normally expect it, or seeing like the legs of the molar, you know, like you'd have the two separate roots. So maybe that's where the Taurodontism comes from. I don't know. I'm just kind of making that up. But no matter what, it's a much larger, blockier pulp chamber. It does look, they should call it like a mermaid thing. I think so too. That makes more sense to me than a bowl. I don't know, a bowl's not. But Torodontism, so file that away in your memory for an exam one day, week 14. To be exact. So bifurcated root. So we can see a little bit right here. This is hard to see, but this canine has some bifurcation here. So it's a little bit hard to see though. Okay, so then we can have alterations in tooth shape. So a couple more terms here. We have enamel pearls, pulp stones, dens invaginatus and dens evaginatus, but let's talk about dens indentae and Leonge's premolar. So Leonge's premolar, I don't think is not on your exam like in that verbiage, but dens indentae slash dens invaginatus, those two terms are, and then this term evaginatus. So just make sure you don't get these confused, and we'll show you some I'll show you some pictures to help you keep them straight. An enamel pearl is going to happen on the outside, and it literally just looks like a little round pearl stuck up in between the roots. So small round radiopacity seen at the cervical portion of the root. A pulp stone is going to be inside. So think of a pulp stone like a kidney stone or a salivary stone. It's inside the gland, it's inside the kidney. And so the pulp stone is the same way. It's inside the pulp, where an enamel pearl is, where's your enamel? It's on the outside, right? So it's going to be on the outside. So pretty easy to recognize the difference there. The dens invaginus and evaginatus is kind of funny because it looks more obvious on an x-ray for the dens indentae. It's harder to see it in the mouth, but this one tends to look more obvious in the mouth and on an x-ray because of the way premolars typically look. So I'll show you some pictures here. Hold on just a second. So here's an enamel pearl. So a little bit of enamel down on the root. So you wouldn't expect to see enamel down there. This will feel like a smooth, incredibly hard, roundish bump. So you will feel this in your clinical experience. You will scale it and go, what the heck? Then you'll look at your x-ray and you'll feel it and you'll go, oh, it's an enamel pearl. And you know, because you'll be trying to clean out somebody's frication and you're like, what is this? So you will come across it. It's pretty common. I mean, not common like, you know, every day, but, you know, once a month or something, or, you know, in your clinical practice. Here's an enamel pearl, and here's an enamel pearl. Now the difference is look at how very, very round this is. Compare that to what you can recall calculus looks like. It's like lumpy, it's like a spur, it's like pointy, like a, you know, triangle, but an enamel pearl is very, very round. But they look sort of similar though, in some ways though, right? Because they're on the side of a tooth. You're like, is that calculus? What's that? Yeah, you probably could. You could take it and then take it on, but well, it would help you know, like if the actual pearl is more buccal or lingual on the tooth. But the other thing is, you know, it's on the tooth, and so you can feel it with your Explorer. And it's just too round. It's going to be too round to be calculus, because you can change the feel of calculus, but you won't be able to change the feel of this very easily. Enamel pearl in the frication. This is a hard one to see, but it's in the frication right in here. It's a little more radiolucent. Now we have a pulp stone. So see, it's right in the middle. Now it might be hard until you get your Explorer out to note if you're feeling a pulp, if you're if it's a pulp stone or if it's an enamel pearl in a very strange location. Like maybe it's a very buccal or lingual enamel pearl, but you'll be able to eventually figure it out just because you'll be able to feel around it and that sort of thing. But the pulp stone is going to literally be inside the chamber of the pulp. So you can't feel a pulp stone because it's inside the tooth. Whereas an enamel pearl, you could. Okay. So the dens indentae or the dens invaginatus, this is like, it's hard to tell from this tooth. You can't really tell, but it's causing this fistula here because of what you'll see in the x-ray. It's just, it's not formed correctly. And so it's caused some problems and some infection. And now it's caused this fistula here, this gum pimple, gum boil. Fistula is like the official word. But it's an infolding of the tooth before calcification. So it happens most often with lateral incisors. Those are the most common teeth to have this dens indentae. And it can occur either with one or bilaterally. So it can happen on both sides. And then we'll look at an x-ray. So see how you have this strange sort of calcification, like it's almost like a tooth within the tooth. It's like the pulp chamber has a tooth inside of it. And so it's like an infolding of all of the material of a tooth inside the pulp chamber. And it was hard to tell from the outside, except for you saw this big fistula, which is this radiolucency, is this infected area. And then have you learned about why a fistula forms? It's like, yeah. So you can think of it as like a pressure release valve. Your body has infection and it's trying to get the path of least resistance to come out and release that pressure. So this abscessed area there's a bunch of pus building up pressure in there. And then your body just burrows a hole to the outside world. And then it's just like a pressure relief. So when somebody has a fistula, they're almost never in pain. They might feel the fistula and be like, I got like a pimple on my gums. And they don't realize what that correlates with, but it's literally like a pressure release valve to release the infection. Yeah.
So that looks a lot like the Pulp Stone.
It does, doesn't it? It does kind of look like it. I don't know that it always would have a fistula, but one thing is a pulp stone is a little bit more circumscribed of just radiopacity, where that kind of has variations a little bit. So I think that might be one way to kind of help. And then a pulp stone, you might see more often potentially in a posterior, and this is more common for laterals. So those might be some things to kind of help. I personally have not seen very many of these in real life, but I've seen pulp stones before. So this whole this whole radiolucent area is the infection, and then what it looks like in the mouth is this fistula. So this is a pulp stone. So that's not going to cause a fistula. That's the dens indentae indent. Okay, hold on. Or dens invaginatus. So let's go back. Dens indentae slash dens invaginatus. But you can just call it, I think on the exam, I might have both terms. I don't know why they give us both terms, but when you Google it, you see dens indentae a lot, but then the textbook used the other term. So it's hard when there's more than one term for something, because it's like, well, which one do you want us to teach? And I wish they'd just pick one, but it does seem like dens indentae seems to be more common. So I have that on the exam. So and it literally means tooth within a tooth is what it means. Okay, so another clinical image of a dens indentae. So here you can see just an extra area on this lateral. So it just looks like a an extra, you know, like a really large cingulum that normally you wouldn't think would be there, right? It's just something extra that's not usually there. No, it's hard. Yeah, it's hard. Can't pop it. Pop this. And then, so then we have another image of it here. This might be that tooth, but you can see how it's kind of unlike the pulp stone. It's in a little different location, and it's almost like you get both radiolucent and radiopacity, where the pulp stone was just kind of radiopaque, right? It was just kind of one, where this shows a little bit of variation. This is showing, this feels upside down to me or weird. I don't know, it's a hard image. But this is the dens evaginatus. So think of in or dens indentate as inward, E as outward, right? And so vaginatus, because you have this outfolding of, so normally on a premolar, if you think about your anatomy of premolars and molars, your cusps come down into fossas, right? So you have all these cusps that are coming down into central grooves and fossas. And in this, they're like coming down and then back up. There's like a little mountain in the middle of the tooth, which is not normal. Like you can see over here, see how they're all coming down into the fossa and the central groove. And here you have this little bulge in the middle. So it's an outfolding of the enamel organ on the occlusal surface of premolar teeth. So most common on premolar teeth, you'll see it. Here's some more examples. Here's like a little, kind of a little pooch of enamel poking its head out of there. And then this is what it looks like on the radiograph. Yeah. Does it have an extra? Oh my gosh, it does. This is that weirdo tooth that had 3 roots. I didn't even notice that. Maybe that's the same picture, or maybe it's just the next one in a series. Because I don't think we saw this before, did we? Or maybe we just weren't looking for it. But yeah, I mean, there's definitely an extra root there. So they got all kinds of interesting stuff, supernumerary and extra enamel formations on their tooth. They got all kinds of neat anomalies. I know, right? They had like crazy cells that wanted to do all sorts of things. Okay, alterations in tooth structure. So then we have root resorption, we have external, and we have internal. And you're going to learn more about this in other courses. So it's kind of more loaded topic. External is oftentimes you can have external resorption of the root surface because of rapid orthodontic movement is one of the most common. Sometimes you just have spontaneous where they don't even quite understand why this is happening. It can be internal or external. And it's almost like, I always thought of it as like an autoimmune. Sometimes it's like all of a sudden the tooth is just digesting itself. But you can see it can be caused from pressure from tumors, cysts, rapid orthodontic movement, or unknown. Internal is the same thing. It can be trauma, exposure to heat or chemicals, bacterial invasion of the pulp, or again, also unknown. Sometimes they're just like, I have seen a perfectly healthy young woman with beautiful teeth lose a premolar because of root resorption, and they never knew why. It just did it. Yeah. They can try to root canal the tooth, and a lot of times it doesn't always take, and then they end up in an implant. And so more and more people are just, they do implants. But historically, that's the only thing they could do is try and take the vitality out of the tooth and then see if it would stop the process. Mm-hmm. You'll learn more about that in oral pathology. Here's an example of the external root resorption, and see how the roots all look stunted. So they just they tried to move those teeth too rapidly. Internal absorption, see how the pulp chamber is just big. So they're just losing it. And sometimes you can even feel a weird softness, or you can actually feel like some change on the outside too. But sometimes you don't notice it until they start to have a symptom, like maybe they get some kind of a pain or infection or looseness, something weird starts happening. Or sometimes it's simply just picked up on an FMX. Like it's time to take your films. Oh my gosh, what's going on with this tooth? So that is another reason why we take our FMXs every 3 to 5 years, even when people are like, I don't have any problems. I don't need to have any films. My teeth feel good. And then they find situations like this where eventually it would have been symptomatic and they would have had some kind of discomfort or something would have showed up with the tooth. Anomalies in eruption. So you can have impacted teeth. You can have transposition, meaning that they come in the wrong place. So impacted teeth, some physical entity has prevented the eruption. So maxillary or mandibular third molars are the most common. They can be impacted in the mandible or in the arch, or they can just be sort of hung up sideways and like sort of partially impacted. They can be covered in soft tissue as well and just not punch all the way out and through. Transposition, they erupt in a place that's not typical. So they come up between laterals when they were supposed to be a canine or something like that. So here's an example of one that's an impacted canine. You see this fairly common. I mean, not super, but it's, you know, you will see it. Here's a bony impaction of a third molar. And you can see how these are kind of a little bit sort of sideways soft tissue impacted here and here. And then this one is kind of heading off in the wrong direction. Soft tissue impaction of the wisdom tooth. Canine impaction. And these, sometimes they'll go in, they'll drill a hole and latch on to the canines and then pull them down into the right place. Sometimes all people's, like people that are older that maybe didn't have as much dental work or they just didn't address the issues, sometimes they'll stay impacted and everyone just hopes that they lie quietly and don't disturb anything or cause any problems. And they just come in without their canines or without whatever tooth it is. But a lot of times nowadays, people try to, if it's kids, you know, they try to move those canines into the right. There's transposition, so a canine trying to come up through the incisors. So then you can have some other acquired anomalies. So these are things that maybe are happening in the mouth per the patient's habits. So we can have attrition, abrasion, and erosion, and they all look a little bit different on the x-rays. Attrition, normal physiological wear resulting from normal function. So just wear and tear on your teeth throughout your lifetime, you're going to get some attrition. Abrasion, abnormal non-physiological wear caused by foreign substances or excessive habits. So this is something extra. And then erosion, damage to tooth enamel because of chemical action, not bacteria. So like sucking on lemons, or somebody that maybe somebody throws up a lot because of a medical condition or an eating disorder, and they have that, or maybe they just have GERD and they just like have a lot of acid in their mouth because they have GERD. So things like that, but a chemical action that's eroding their teeth. So here's what attrition looks like. You get this real flat surface, and see how everything just looks real, just the same, like flat. And when their teeth come together, it's just like, you know, two boards coming together. It's real. And what happens is they wear down to the pulp chamber, but their pulp puts up a defense and starts building up like secondary dentin to like protect itself as it comes through. And so sometimes you can really see where the chamber is, but it's not like they go, because they do it relatively slowly, but it like their pulp chamber kind of shrinks as they go. But I've seen like kind of people have worn it so much you can almost see like a pinkish tone, and you're just like, ah, you're just like, you know, they're just wearing it right into their pulp chamber. Here's another example of attrition. And then here's abrasion. So we have what we used to call just toothbrush abrasion, but we also call these like abfractions now too, because they have found that people who clench and grind, the weakest part of your tooth is it's like, if you think about like a post in the ground, if you are super strong and you can break a post in the ground, where is it going to break? Are you going to break off the top, or are you going to break it at the ground level? Like if you're able to break a post. So that's kind of what's happening here is people who clench and grind, they have like micro sort of like kind of sloughing off. That's not probably the best term, but they lose that enamel at the gum line. And if they have other habits like heavy brushing or, you know, like some kind of poor oral hygiene or something, it can aid in that. But they have found that some of that is just based on occlusion and force and trauma from bite. So abrasion or abfraction is another term. I think you'll learn about that in one of your other, maybe perio. Perio might talk about that. But that's what it looks like on the X-ray. You can see it kind of looks like a bit of a uniformed, sort of thinned out area. Sometimes it looks a little more radiolucent because it's thinner, so it looks a little darker. Erosion, so this would be like sucking on lemons or acid from either vomiting or stomach reflux, GERD, that sort of thing. And it just looks more radiolucent again because you're losing tooth structure. So anytime you lose structure, it's going to look darker, so it'll look more radiolucent. Erosion. And then, so here's an image. It's the question, which anomaly or anomalies, oh, come on. How did it do that? Are present in this lateral. So right here, here's our lateral. Dens indente, dens evaginatus, orthodontic root resorption, A, B, and C, or A and C. What do you guys think? Good job. Just smart. That's right, A and C. So you can see the dens indente here, and then you can see the root resorption there. Okay, non-tooth related. How long do we go again, you guys? Are we done? Oh, pardon me. It's class goes till 2:30, 2:50. Don't we go to 2:50? Are you trying to, you guys don't understand how confused I get because my other class starts at 1:30 and goes to 3:20. And I always get you and them mixed up. So I'm always like, am I early? Am I late? Am I running out of time? It's a constant stress. Okay, non-tooth related miscellaneous, let's see. Mandibular tori. Tori is the big bony blobs down at the bottom. It's a nightmare to take x-rays on people with mandibular tori. I have monstrous ones. If you ever want to practice, you can do it on me. I have huge tori. And so it's really hard to get in between the two. For whatever reason, my husband has giant ones too. We both grow big mandibular tori. But you'll see it will look more radiolucent around the premolars. Sometimes you'll see like sort of little, blobs or I don't even know what I'm trying to say, but you'll see extra kind of rounded formations in the x-ray. Maxillary torus, because it's only generally a torus and plural tori on the mandible. So a maxillary torus, generally you're not necessarily going to see it in the maxillary images, but you will see it intraorally, and it might make it difficult to take x-rays. And it's not as common on the palate, but you will see it. And sometimes, boy, oh boy, are they strange shaped. And it can be, because you don't see it very often, it can be like, what's that? Oh, because it will fold. Like I have seen some that grow and then fold under. And then, so it's almost like things could get stuck underneath. It can be very odd, but it's not as common as the tori. You see a lot more tori. And people have had this stuff removed and the bone grows back. It's just bone that wants to grow. Retained root tips that can look like this. And then Halloween teeth. I don't know why that's there. Okay, I'm gonna we have 20 minutes and I have one more short set of slides and we're going, people, we're gonna do it. I know. Just hang with me, because just think, if we get it done here, then you just don't have to worry about like listening to it over break, right? Okie dokie, Smokey, hold on. stop share. I know. Okay. Interpretation of periapical lesions. And like, yeah, if anybody needs to step out, don't worry. It's recorded, so you will hear it. But if we can go, we can go. We can keep going. Okay. So now we're looking at, so those are all anomalies. Those are all variations of normal that you might encounter on your walk in your clinical career. And then now we're going to talk about different periapical lesions that you might see and kind of just being familiar with what they look like. So identify different types of periapical lesions on radiographs, describe periapical lesions, identify local factors contributing to periapical lesions. So here we go. So causes of periapical lesions. So we can see here in this picture, you get some radiolucency. Causes can be some deep caries. This is obviously like a really big caries. There's a lot of tooth missing, and it's come down to one of these pulp horns. The deep caries, trauma, perio, you can have a periodontal pocket that's so deep it's gotten down to the apex or close to, so that bacteria has now invaded and caused an infection down in the pulp. So you can have, or a twofer, you could have it be perio and caries related. Inflammation from the pulp extends to the bone around it. So that's what's going on. You get inflammation in the bone down there. And the infection, the actual act of the infection and the cellular act of what's happening there causes the bone to resorb. So that's why you get this radiolucency, because you're losing the bone there. So here, up here in this picture, A, so A, B, C, up here in this little black and white image, A is showing the widening of the periodontal ligament. So here we have the widening down here. That's the first sign. So you take an X-ray and all of a sudden you start to see a little bit of the widening of the PDL down at the apex, then you kind of might go, ooh, what's going on here? B would be a radiolucency encapsulation. So it starts to really get, the bone starts to go away and the radiolucent area enlarges. And then C, periapical radiolucency, it's not encapsulated on the mesial root, but it is with, what's it saying? With condensing osteitis. So condensing osteitis is this area here around the distal root where the bone has basically tried to wall off and build up bone. So you can see it back, sorry, it advanced on me. I don't know why it does that. But you can see here how it's much more radiolucent around these roots. So the osteocytes or the bone, it's condensed, it's gotten thicker. So you can kind of see the definition just by the verbiage, condensing osteitis. So a couple more terms, we have apical granuloma, most common periapical radiolucency in the dental practice. The reasons why this could occur is from chronic inflammation. It's the body's attempt to neutralize whatever is causing the irritation. Often it's asymptomatic. The tooth is going to be non-vital, so they are going to need a root canal. Then we have an acute apical abscess. So it's something that's happening kind of acute. Whenever I think of acute, I think of it's coming in hard and fast and it's probably uncomfortable. Chronic is more like slow and maybe it's not even that uncomfortable anymore. But you think of like chronic disease, it's just with you, you're kind of living with it, you're maintaining. But acute, like acute appendicitis, it's coming in strong and hard and it hurts. So that's how I kind of helped me remember those phrases. So acute apical abscess, painful localized collection of pus, very symptomatic. Pain is a symptom, so symptomatic. The tooth is going to be likely non-vital and will need a root canal. Chronic would be like a fistula is going to form. So the infection's been there, a fistula is going to form. It is going to need a root canal in order to solve the problem and get the infection out of the way. Okay, Periapical lesions, so they're going to be well defined at the apex. So you can see some examples here. These are well defined. Tooth has a crown post without endo treatment. So very oftentimes, like this one has had a post, but there's no endo. And you can see there's still some radiolucency up here. These haven't had any work on them. So, you know, that's a little bit more of a mystery. That's probably a combination of like a perio. And then this is probably from just a chronically irritated pulp chamber causing some inflammation and infection down at the roots there. Periapical lesion, relatively well-defined radiolucent lesion at the apex. You can see it's pretty well-defined. Tooth has a large restoration. So these large restorations can just makes for a more unstable environment for the pulp chamber. It can get irritated from hot and cold or like pressure from biting. And that irritation can just lead to problems. What could be in a radiolucent lesion? So then we have other kinds of lesions, like there's this huge one here, So then what's inside of that? Well, and star this for an exam question. You could have air, you can have fluid, it could be cystic fluid or blood, you could have exudate, which is pus, or you could have soft tissue. It's impossible to know until you've done a biopsy or they've gone in there and opened it up. Sometimes, yeah, sometimes it can be swollen, sometimes not, like it's just, they don't notice it till they take a film, but sometimes it can be swollen for sure. Like here, this guy is swollen. So acute exacerbation of a chronic periapical abscess. There's some swelling down in here, and then you can see a little bit of swelling in his face too. A lot. Yeah, that's scary. Oh, that's scary because you think of all that infection and how close it is to like your brain. I mean, it's really, it's a bigger deal than most people. Like that's why oral health is one of those subjects that it doesn't always get the attention it needs for those kind of things because it's really a big deal. Well, then there's the whole fear and the financial, there's so many layers. It's hard. Periapical lesion, acute exacerbation of the chronic periapical abscess. So you can see this is just some more images showing it, and you can see how large it is on the pano there as well. Here's just another image of a periapical abscess. That one is probably a root canal that failed. Periapical radiolucencies. So apical cysts. So here we can see different images of cysts. They look different from a periapical abscess because they're, for one, they're going to be big. Sometimes they have a lining, like a maxillary sinus has the floor of the maxillary sinus. It's like a thin lining. Sometimes you'll see that with the cysts. So painless, unless infected. Tooth is typically non-vital. So meaning when they do a pulp vitality test, it doesn't show anything. They don't respond to it. Usually it's bound by a thin line of sclerotic bone, usually larger than a granuloma, but it originates oftentimes from a pre-existing periapical granuloma. So there's some kind of cellular change that just kind of went crazy in that area. So we have periapical granulomas, which can be acute periapical abscesses. You can they can turn into chronic periapical abscesses, or they can go from chronic to acute. And then you can also have apical cysts. Let me just read my notes really quick. So whether acute or chronic, a tooth with a periapical abscess is non-vital. An acute periapical abscess is painful. Pain may be intense, throbbing, constant. The tooth is sensitive to pressure, percussion, and heat. A chronic periapical abscess is usually asymptomatic because a lot of times they have the draining fistula. So that is what helps it be asymptomatic, is because it's draining. Okay, so biopsy, they have to biopsy this to prove what it is, that it's a cyst. And then this is what the surgery sort of looks like. They cut in there and then they pull out this cellular mass, and then they can also see what's inside of it. And they'll do that with a biopsy. Radiograph interpretation. So periapical lesions. So a couple different things. So that condensing osteitis. So it's like the bone just looks condensed, like it's thicker, there's more radiopacity. It's the body's attempt to wall off the inflammation, and radiopaque border around the root tip. So you can see all of this extra sort of white area is the condensing osteitis. You can see it around here too. All of this extra white around the radiolucent area is the condensing osteitis. The bone may or may not go back to normal. So they extract, this is all condensing osteitis. They extracted this tooth and years later, it still was there. So the bone might always look, so that's why chart notes are so important. Like what happened? Like this person goes to a new practice and they take x-rays and they're like, whoa, what's going on? And if the person doesn't remember or the chart notes don't follow them, then they can't say, well, 8 years ago, I had a tooth taken out and this bone's always looked that way ever since. So that's why all that documentation is really important. Some other things, so periapical cemental dysplasia, it's benign, slow growing connective tissue proliferation. So inside here we have, you can see how it's radiolucent with some radiopacity inside. So it's connective tissue growing inside these areas. This again, it's kind of cells gone wild. They're just doing different things. It destroys the lamina dura and replaces the trabecular bone with fibrous tissue, varying amounts. So it can look like this is a lot, looks like a bunch of like snowballs or something, or it can just happen around this one tooth, probably triggered because of the trauma of this root canal is what I might assume. Or maybe that started and then they needed to do a root canal. Who knows? Chicken before the egg. Mm-hmm. Oh, like this one right here? Yes and no. So yes, you could, like if you were really reaming on the tooth and if they have this very unstable environment, there is a possibility you could extract the tooth. You will scale teeth that you have to hold on to and scale. It will happen in your lifetime. But a lot of times things actually will move and they won't just fly out. It actually takes a little bit more force than you would imagine to get something to come out. So usually just scaling on it won't do it. But at the same time, everyone does different, everyone has different forces. So it could happen. Okay, star this one for an exam question. Periapical lesions of non-pulpal origin. Periapical cemento-osseous dysplasia. So similar to what we just saw, but different. Some key things, mandibular anteriors, and predominantly happens among, or is seen among African-American females. So that's a few things to help you differentiate between the two. But you can see it's not quite as radiopaque. There's not as much different tissue growing inside. It's more of a dysplasia as opposed to this one. You can see there's a lot of kind of extra tissue coming around. So it's filled with a fibrous tissue where this one not. So just remember the difference there for an upcoming examination. Periapical radiolucencies related to periodontal disease. So again, we can have periapical abscesses that come on because of our level of bone loss and disease in the mouth. We can also have periapical lesions due to trauma, traumatic tooth injuries. You can see fractures coming right across here. There's a fracture in this root. There's a big old fracture here. And so you can see these, and then you can get infections and radiolucencies that come along with all of that. Here is just another example of radiolucency. Here are some more radiolucencies. This, you can see there's all kinds of something happening here because there's like some filling material and radiolucencies close to the pulp chamber. This is condensing osteitis. This is an image from earlier. I think it's just repeated. This is radiolucencies that are likely having something to do with the amount of bone loss around the teeth, just because there's a lot of bone loss there, so that you can end up, there could also be some root caries there, which it looks like there might be. Here's another radiolucency around this tooth here. Definitely there. And then here's another tooth fracture. You can see the root fracture up in here. And then another thing that you can see is sometimes on teeth that have been extracted recently, you can actually see the outline of the socket. So if you see this on an exam and it asks what you're looking at the outline of the socket. You can still see a little bit of the outline of like. Patient history is important because that's going to help unsolve these mysteries. Sometimes if it's unexplained and the patient doesn't remember, it can be really tricky. So you always want to document stuff and then try and ask questions about their history. If they had injuries, if they fell off their bike or hit their face on the deck or whatever, you just try and figure out what's going on. And that's it. Now you guys, I cannot believe that we got through all of that. I'm very proud of myself. And I'm proud of you for sitting and listening to all of that. So thank you very much.